Thank you. That was so nice, Wesley. Thank you very much. So I wish I could be there in person, but I'm going to do my best here. This is, I think, and it's going to be sort of a whirlwind, but I tried really hard to kind of synthesize everything to date about the war on melanoma so that everybody has a really good idea. You know, some people know a lot about one part of it and nothing about the rest. Some people know a little bit about all of it, but don't know, about the big picture or the details of individual projects. So I thought I would sort of give you a whirlwind tour, and hopefully I can finish fast enough that if there's questions, we can do more in-depth questions or whatever. Conflicts of interest. The main thing is we've gotten some unrestricted educational grants from Castle, and then I'm going to talk about SCLIP, and I think that's all I'm going to talk about in this one. So what is the war on melanoma? At its roots, it is I'm going to put this down here maybe so I can see that. At its roots, it is a statewide public health education experiment. And it's grounded in the hypothesis that a broad, statewide early detection education program that tailors methods and content to the different members of the community are going to improve knowledge, attitudes, and behaviors, and also reduce death and costs due to melanoma. And so the way that it started was when I was recruited here, right at the time I was recruited, Night Cancer Challenge started. It was like that my very first event with Night was the Phil Knight announcement of the $1 billion challenge. And so that initiated, since that was early detection, we knew we wanted to focus on early detection, and we initiated this melanoma program to really, really drive it forward. And we started to plan trying to educate the entire state, if we could, on melanoma and the risks so that they could detect it earlier. Then in 2014 to 2015, we developed a melanoma community registry I'll talk about. We developed an app called Mole Mapper, which is a mole tracking app. And that app was designed to try and allow people who didn't have access to care to be able to track it themselves, and people who do have care to track it better. We partnered with the Oregon Derm Society, and we started community screenings and awareness events. And it started to ramp up. And as it ramped up in 2016 to 2018, we went nationwide and kind of to the extent of notifying people we were doing this, so that people all over the country started to pay attention to what we were doing, and in preparation that when we found out the answer, we could pass it on to them. We started e-visits because I was really, really worried that if we did really well with this campaign, then maybe there'd be so many people coming in that e-visits and e-consults were going to be necessary, because otherwise it would swamp the system and all of the PCPs would not be able to take care of all the seborrheic keratoses that came around. We developed a strong rural health outreach I'll talk a little bit more about. We designed 3 separate curricula that I'll talk a little bit more about as well. We started a CME roadshow to all of the PCPs all over the state, especially in rural areas. And we started really large-scale screenings where we would see 300 people, and we would have big events around them. We also started partnerships, a lot of partnerships around the state with the Oregon Health Authority. In particular, one of the benefits was that with that partnership, I was able to go to the licensing boards for every skin care industry, whether it was tattoo artists or massage therapists or hairdressers. I could go in front of them, and they partnered with us to help get out the word to their membership. We also partnered with the Oregon Medical Board, who got the word out to all of the physician membership. We had partnerships with our PCP Council at OHSU that extended out also into ORPRN and OCHN. And we also got a PCORI pilot program grant as well. Then what we did is we did a baseline analysis, which was a population survey, cancer cost analysis, media analysis, and then we did our first pilot intervention. And then unfortunately, COVID hit. We were planning to do a follow-up intervention immediately after and then measure it, but we had to delay because of COVID. And so our next intervention came in 2022. The benefit was that we were allowed to analyze what we had done in the first pilot intervention more carefully, and we got a much bigger bang for the buck on the second intervention. Then we repeated our death and costs, all of those population study, to see whether or not from the baseline, relative to baseline, after that intervention, had we increased knowledge, improved attitudes, and gotten a better report of self-skin exam behaviors. And that was the repeat analysis. And then we did in the future, the idea is that we'll repeat that hopefully, and also the cancer and cost analysis in a bit. Now the cancer and cost, that's the cancer registry, and the cost via I'll tell you a little bit more about that, how that works later. Okay, so you can think about the war on melanoma as having 3 phases. The first phase is that 2013 to 2019, where we developed all that infrastructure, right? We had the registry. I won't go over that again, but all that infrastructure was developed. The second phase was from 2019 to 2022, when we did the major statewide mass media and all of the implementation of all of the educational interventions. And then the third phase was 2023 and after, when we started doing booster, sort of these little booster media things that we did. Now, the literacy survey we did in Oregon, Washington, and Utah. And as I said, it was designed to test, literacy is considered to be, in our case for this particular project, knowledge, attitudes, and behaviors, because those reflect the chance that people are paying attention to their skin and are actually going to do a skin self-exam. So it's a good marker for that. We also then, as I mentioned, looked at our cancer stats and our cost survey, the cancer being through SEER and OSCAR, and the cost surveys being through a program called SEER Medicare and the All Payers, All Claims database. And so that's what we've got, right? And what we're going to start with, the first part of the talk, is going to be to talk about the actual intervention. What did we do? What happened with the media? The second part of the talk is going to be about the results of the literacy survey, because we have now a baseline and after that we can talk about what happened. And the third part is to talk about where we are right now on the cancer stats with respect to SEER, Medicare, OSCAR, and APAC. So part 1, there we start, the primary intervention. So it's a mass multimedia educational campaign. It's statewide. As I said, 2019, we ran the first one, which was the Start Seeing Melanoma campaign. It was created by a company called Sockeye. It was more expensive and less effective, and I'll show you that. And we learned a lot of lessons from that. The second campaign was the bigger campaign in 2022. It was called Melanoma Stands Out. It was created by our own OHSU marketing group. It was less expensive, more effective, and we learned more. And then 2023 to 2027, our boosters with the Melanoma Stands Out campaign, just making it evergreen in selected media. And it was the media that we knew was going to give us the biggest bang for the buck based on the first 2. So where are we reaching in terms of the war on melanoma? I sort of have alluded to this, but we wanted to hit all parts of the state. And we knew that we needed to hit the lay population. It's about 4.2 million. And we knew within that population, the skin service industry, those tattoo artists and all those guys, are about 40,000 licensed service workers in the state. We wanted to reach them. We wanted to reach all of the primary care providers. And these are the primary care for not just MDs and DOs, but also we looked at chiropractors and other nurse practitioners and PAs. And so anybody that was considered a primary care through the Oregon Health Authority. And then also dermatology and melanoma experts, which we have about 200. So the goal was to direct our our educational missions, all of our education that we're directing into each of these different populations in a way that it would be tailored to them. So the first one is the lay population. And like I said, I am not going to go through every one of the people that were involved. It was an amazing group of people. We reached out to the lay population. We started with the sockeye. This was the sockeye experiment. It was a public health campaign. And it had two main messages, which is unusual. Most of the time they stick to one, but we knew if we only said, look at your skin, if we didn't also say, if you see something, do something, it was going to be a problem. So we through sockeye, these are some images that we developed in collaboration with the sockeye group. And following the release in 2019, we then did a follow-up community engagement studio. And I want to send out kudos or thanks to the community, to our own NIGHT community outreach and engagement group, because they helped us to do this studio. The goals were to get feedback, to understand their perceptions and receptivity, and to learn what kinds of messaging resonates. And so first of all, we found out, what is your initial impressions? The overall comments in the urban area were mixed, but more negative than positive based on this. The rural, almost all, I mean, they really did not like this campaign. And you can see things underneath that. Why are they all naked? Look at what? I don't understand what I'm looking at. Intimidating photos. Is this a human trafficking? You know, all kinds of things like that. This is just another example, just more dislikes than likes. And here again, the personal story in the urban area resonated well. That was something they wanted, but a personal story was not compelling to the rural area. So we were faced with the fact that we really wanted to make sure some of our highest rates of melanoma death in the state are in these rural areas. We couldn't afford to not reach the rural area. So we had to develop a different marketing campaign. And so this one was developed by our own OHSU marketing. It's called Melanoma Stands Out. And you can see the idea is still the same. Look, and if you see something that looks different, you can spot it. It was a little bit more self-efficacy because we had gotten some information that was a really important thing. And the thing about, we learned from the first survey that the knowledge that there was, if something looked different, made it concerning, was very low in all of our populations, that question in particular. So this campaign was directed in that way. And you can see it was on billboards and buses and everywhere. And I'm going to see if I can play this. I hope that it plays where you can hear it.
Melanoma, the most deadly form of skin cancer, has a 99% survival rate when treated early, but that drops to 30% when caught late. Melanoma stands out. It's the cancer you can spot and stop with your own eyes. By checking your own skin, you could save your own life. So if you see a spot, talk to your doctor. Check your skin. You could spot cancer. Learn more at startseeingmelanoma.com.
So that was the campaign. And it went really well. As you heard, it was my voice. We saved money that way. Paying voice talent is expensive, so we saved some money that way. But we also had a social media campaign going, and we wanted to make sure that we were reaching out, but we were reaching out in the best possible way. So as we reached out, we also did some testing. And ultimately, this resulted in a really great collaboration with Autumn Schaefer and with Ellen Peters they're down at the University of Oregon. And our ultimate finding on this particular thing was that if we wanted to increase, that if you increased both knowledge and confidence in how to do a skin check, that may be the most effective thing in improving the accuracy of skin self-exams and intentions to do them, which is correlated with actually doing them in reality. And so what this showed us was another piece of data that led us to that second campaign, which is that we wanted to make sure that they were looking at the right thing and that we were making sure that their knowledge was increased a little bit. So in addition to having the social media, we, as I mentioned, we had, and I'm going to see if you can, I hope you can see my pointer. We developed a very, very strong online platform on our website. We had two websites. The first was the waronmelanoma.org, which is housed within OHSU. And then we also have the startseeingmelanoma.com, which is housed outside of OHSU, but contains basically the same material in a less sort of clinical or sophisticated way that would be for medical people, because we knew that people, and we knew that people from other places, like we were hoping that, you know, like Providence and Kaiser and all those would also be more likely to see it at Start Seeing Melanoma. And so we made a curriculum that we put on here, and I want to give huge shout out to Liz Stews for this, because she was amazing. She is an amazing educator, and she was the one who really led the whole development of all the curriculum. And we have a separate curriculum for basically this Learn About Melanoma is for all the lay people, and it's the same here. We have for medical professionals, we have for the skin care professionals, and we have the ability to join the registry here, and we have the ability for any of our professionals that want to have advocacy or educational materials to get them directly online, things that we have vetted that are outstanding resources. We also created an app. As I mentioned, I wanted to make sure that we had a way to give people something if they didn't really have access to a dermatologist to help them. And this was done in collaboration with Apple, with a thing called Research Kit and Sage Bionetworks, which was through the Bridge. And it was an IRB approved app. It allowed users to photograph lesions and submit the data to OHSU for research. This is one of the rare cases where we actually have research that has been done with you know, an app that is out in the real world, in the wild, as they call it. We've had over 31 participants from every state. 20% of those 3,100 were from Oregon, understandably. We advertised it more here. Over 19,000 downloads, 33,000 measurements, 36,000 curated images, and it's now created the largest publicly available collection of smartphone photography, and it's being announced in Nature. Well, we hope it is. It's in review. Nature Scientific Data. It is being reviewed. We think it's going to get in. We hope. But as you see, it stopped in 2022 with respect to the research component, because it was very expensive to continue to update it from the software engineering perspective every time Apple changed something on its app, every time we got a new version. But we decided to go ahead and publish all of this. So this is what we found in this is that the artifacts, especially blur, I think, if you see that, that's the one here. These are all different artifacts that people accidentally get into the app or into the photo that they've put in the app. And so you can see that all of those impact the usability of these photos. So it wasn't as good of a citizen science. The idea was to really get this citizen science movement going, but it just really, the artifacts made it really too hard. And we even had educational things on here, how to do it right, but it just didn't work. The other thing is that habit formation, the other really strong thing about this was that we were going to get the idea was to get longitudinal photos so you could see things if they were changing. But unfortunately, we also weren't able to get habit formation to really take place. So it was a great idea, great effort, really useful information, but didn't really do as much as we had hoped. It's not going. See. So here's just a summary of that Melanoma Community Registry. As I mentioned, the Melanoma Community Registry, we started by partnering with the Oregon Cancer Registry, and we got them to act as an honest broker for us that would send out to every living melanoma patient, which was about 20,000 patients, and we had another 5,000 within the OHSU system. And we sent out a letter inviting them to become a part of the registry. And what you can see is by 2014, we had 3,065 that had all come from our website from Oregon. And then we opened Mole Mapper. Like I said, we started Mole Mapper. And so you could also register via Mole Mapper. And so what you can see is that at this point, we have about 6,000 people in our registry from Mole Mapper and about 6,600 from our website. And out of those, the majority of the ones that came through Mole Mapper do not have melanoma, report not having melanoma. And the people that are from our website, the majority have had a melanoma, but there's about almost half of them that have not. So it's a nice resource to be able to get the word out. We can contact these people. We have permission, IRB approval, to contact them at any point to advertise any community event, to provide them with additional information, etc. Okay, so the other thing we had is a high school program, and the high school program has so far reached 13,000 students, 107 schools, and 26 out of 36 counties. All of this is published, but the knowledge scores improved both in our pilot phase of the educational curriculum as well as the implementation phase. And we got a statistically significant, pretty dramatic improvement in confidence in checking their own skin, confidence knowing when to have it checked, when to have a mole checked by somebody else, and encouraging friends and family. So this looked very good. We also reached out to the skin crew. So in addition, as I mentioned, not only do we have the lay population, we have this subset that have a really high knowledge about the skin. And again, this is published, but we showed that when we looked at their ability, their overall percentage of correct answers, and we looked at it pre-training, we looked at it immediate post-training, and a year follow-up. And what we could see is that we did see their overall increase in the percentage of correct answers. And we also saw that, importantly, one of the things that was a marker, we felt a very strong marker for whether or not the skin industry was going to feel comfortable actually telling a client that they had something on their skin that they needed to have checked, was whether they had this confidence, their comfort level in sharing that. And as you can see, it went dramatically up post-training, but unfortunately went back down. I think that suggests it didn't go back down to baseline. We did gain some improvement, but I think that suggests you need boosters that are more frequent, probably at least once a year. And then we had a student who did her scholarly project, Hannah Zhao, who looked at, she was getting frustrated. If we send out, 40,000 emails and not that many clicks come back, because we were watching if they were coming back to the website, and not so many were coming back. And so she said, I'm going to look into the behavior and the relationship with the way that the language is tailored. So she made up emails. She took 10,000 of those and she divided them out, and she developed an email that really focused on the attitudes, focused on another set that focused on self-efficacy, another that focused on perceived norm, and another that was completely personalized to that person, and looked to see which ones gave her the best click-through rate. So which ones did they actually, that's a percentage of those that clicked, that opened the email, or that was delivered, that the email was delivered. So as you can see, self-efficacy is one of the big ones, which makes it really, really nice, because that's one of the things we say in our campaign is you can spot cancer. You could save your life. And so that's really nice. And we also have here that personalizing it really didn't change. There was no statistical significance. This was all measured against the generic control. Okay, so we reached out to them. How many did we get? We did so many outreaches. 28,000 targeted through emails, 207,000 sent by the Oregon Health Authority, 35,000 postcards, 9,000 but this is amazing. 9,000 individuals participated in the training at some level. That was amazing. And 46 out of 150 invited schools. Now, these are not the high schools. These are the beauty schools. 46 out of 50 joined, And we have over 1,200 skin crew members. Those are people who have gone through the complete program and have been very active. And you can see here, this is the area of the state that covers the people that are part of our program. And these are the places, the schools and businesses that are participating. So now what about the primary care? The primary care providers also need to be contacted and reached out. And these are the people who have helped with that. We did a PCP pilot study to begin with to make sure it was valid. Part of that, it was a toolkit. It had multiple different ways that a person could learn over whether it was quick or if it had a self-test or if it was just images. So we did videos that showed screening. We had image recognition that were multiple photographs. We had biopsies. We demonstrated how to do different kinds of biopsies and how to understand the path. We showed risk factors and smart phrases for their electronic medical record and patient education, and we had CME. And again, this is published, so you can go back and look at this, but basically when we tested the percent correct, it went up. The identification of malignant lesions in these PCPs went up. Confidence in identifying malignant lesions improved. And on average, the respondents answered more knowledge in image questions correctly on the post-test than on the pre-test. And here's the PCPs. So you can see the darker orange is where there's more of the PCPs, and the places that are sort of the primary care deserts are noted in gray. And you can see we sent out 30,000 digital newsletters. We had 1,800 providers that we reached through in person through grand rounds and PCP conferences, 770 through in-person outreach, 829 have used the PCP toolkit. That's actually quite impressive that they've used that. And you can see those people who have used it in the blue shading. And you can see the places that we went in person with the little orange map things. So finally, the derm and melanoma experts. And I think one of the things that was really cool is the SCLIP. We used SCLIP to try to educate people, and it's a dermatoscope that fits on your telephone or your iPad. And it was developed by Joanna Ludzik and Alexander Witkowski. And it really is nice because it gives you better photos to look at. And we then attached it to our e-visits and e-consults. And I want to note Terry Greiling here in this one that is really, she and Melissa Schwartz and Ty have done a lot of work on these e-visits. And as I said, we knew we wanted to start these e-visits right here by this time. So we started them early so that when the 2019 campaign launched, it was already in place. They were already working, and boom, you can see an increase in both the e-visits, which are in orange, and the e-consults, which are in blue. And you can see that when COVID hit, it was really great because we had already started it. And again, boom, these e-visits really magnified because there was not so much access to care. And I'm not, at this point right here, the reason it went down, it probably shouldn't have gone down that much, but there were so many that we had to only include the ones that were neoplasms. But as you can see, this is really, really great, the number of e-consults and e-visits we've been able to get, over 6,000 by now. And this is what happened when we added a SCLIP. So we got a SCLIP loaner program going where we were able to mail out the SCLIP to the people that we couldn't tell just by the regular photo that they sent in whether or not this was working. And when they got a SCLIP and used the SCLIP, we got a 53% reduction in the need for those people to come in. So almost half of them, they didn't have to, a little over half of them, they did not even have to come in. We could say that it was benign and they could watch it. It saved patients an average of $67 per visit, and 1 out of 6.4 people that we did tell had to come in ended up having a biopsy-proven malignancy, so it was good that they did. And so this is just showing how the distribution of all of the telecare that we've been given And this is the other thing that we do is mobile screenings. And I think, you know, that everybody at night hopefully knows this is a picture with KCI, but we partner both with KCI, who has a mobile van, but also have been strong partners. And I want to, with the Night Cancer Institute mobile unit, and I want to call out Derek Zembrowski for being an amazing leader in that area. And thanks to all the community outreach and engagement program that we have for that. So what have we accomplished to date? We've had 9 screening events in 2022, 15 in 2023, 19 in 2024, and this is the number of patients screened. The total screening, 43 screenings, and 899 different individuals screened. 38% of the participants reported coming to the event because they had a spot they were concerned about, and 26 reported that they came because they do not have a dermatologist or health insurance. And here you can see that 20% of the individuals who got a skin check were recommended to follow up. And the most common thing that they were recommended for was a dysplastic nevus. And it's 5% have melanoma overall, which is not trivial. And finally, we added a teledoc to the mobile van that KCI is able, or not KCI, sorry, that I should say Night Cancer Institute mobile van helps us bring this around so that we can use a teledoc if a provider is not able to go with the van, that we're able to do teledoc with the medical students and the van in very remote rural areas. And we've partnered also with an outside group called Team Truck Melanoma that was started by Ryan Kiernan. And we go to some of the mobile outreach things that he does, even though he's an independent partner. He comes to ours, we go to his. And it really emphasizes, his group emphasizes motorsports enthusiasts and other really high-risk populations that have specialty events like beer fests and things like that. And so this is the overall thing. This is our overall 2022-23 overlay. So radio stations, those are the radio stations, 45,000 spots. TV stations, 10,000 spots. Local newspapers, 36 newspapers. Billboards, 4 billboards. You can see the billboards are primarily in large urban populations because that's where you're going to see them. High schools, you can see the reach there, and the community outreach efforts. And if you look at the numbers, the total for 2022 is over 100 million. Now that's a true campaign. That's a legitimate number of impressions for campaigns that are for like suicide or diabetes and things like that. And in 2023, we got 53 million impressions, and you'll see that that based on the spacing of all these, 98% of the population of Oregon lives within the areas that we were able to reach, and over 154 million impressions were delivered just from 2022 to 2023. But what about what happens? So they saw it, they may have seen it. These are impressions. They should have, you know, they were exposed to it, but did it cause them to go to a website? This is our website, and it shows that you can see where the pilot campaign came in, where the Skinny on Skin promotion, where you got the big campaign here in this 2022 area. And then this is our booster campaign in 2023. And these are the page views that come in, and it's not bad. I mean, if you look at these months, I mean, we're talking, you know, up into the 2,000 to 3,000 range. And this is the bang for the buck, right? So you've got all these different ways that you can reach out, that we've reached out to people via print, billboards, social media, all that. This is what we did in 2019, right? This is what we did in 2022. So this was the Start Seeing Melanoma. This was Melanoma Stands Out, and these are the boosters. And as you can, I'm not going to go through every number, but I think you can see that we got 20 million impressions from the 2019 campaign for $193,000, whereas in 2022, we got 100 million for 115. And in 2023 with the boosters, which we narrowed down to the ones where we got the best results, 53 million for only 35,000. So to date, this is about 175 million impressions in that area of intervention for $343,000. It's remarkable. Okay. Part 2, the melanoma literacy outcomes. So now this was a 3-state general population survey. It included Oregon and Southern Washington that carry where you could see where all of those radio and TV went. We counted that Southern Washington that was in that range as part of it. They received the intervention. Washington and Utah were considered control states without the intervention. And knowledge, attitudes, and behaviors I just want to reiterate strongly that those are considered to be the best surrogate for self-screening. And so that's why we really were looking at this as for literacy. So here what you can see is we had the knowledge, attitude, and behaviors. This is the screening survey that we sent out to 15,000 people twice. The first time we sent it out, we got about 2,300 respondents back. The second time we sent it back, it was about 1,700 or so. But you can see that the distribution is pretty good, and it was very similar for the pre and the post. And we were able to also compare the answers to the Warren Melanoma Community Registry, which we sent it out to them and got a great response back from them as well. I'm not going to have time to talk about what that community registry showed, but what I can say is that we identified in the first campaign areas of knowledge, attitudes, and beliefs that really helped us to prime exactly what our specific messages were in our campaign. This is the results of the demographics, what you can see from the literacy survey. So what you can see is we looked at age, gender, education, ethnicity and race, income, marital status, insurance, community type, rural or urban. And we looked at it. This is the baseline survey that we did, and this is the follow-up survey that we did. And I think you can see that they're all remarkably similar. There's a few differences. For example, there's more married people in Utah, but that's not surprising. We know that it's kind of really nice to see that because we know there's a higher marriage rate and a higher birth rate. And you'll see there's a little bit higher a shift of the Utah to be less, younger. And those are all really, really great things. So what this says more than anything is that our control states that we're using are valid comparators to Utah, so that when you're comparing with and without the intervention, you can tell whether or not you have a good chance of telling whether there's a difference. So this is kind of the depressing part, is because when we did the melanoma literacy at baseline and follow-up, what we saw was there was no real change. We're looking, remember, literacy is confidence in performing the self-skin exam, percentage reporting that they are actually doing a self-skin exam, and the number of items that their knowledge level, the number of items answered correctly. And the follow-up, so the baseline is red and the follow-up is blue. And you can see that there's nothing really statistically significantly different when you look at the general population. Well, I had hoped we were going to move the entire general population. We didn't quite do it. But what we also did, this is the good part, is that we also looked at melanoma literacy in those who actually reported seeing the messaging versus those people who reported they didn't. And when you look at the ones who say that they saw the messaging, then you do get this statistically significant increase in confidence in performing self-skin exam and in the percentage reporting. Look, 72.6% of the people who say they saw it in Oregon say that they're doing their self-skin exam now. That's remarkable. So that's pretty cool. And I think this is kind of a major deal that we're getting ready to publish. And questions about that? There is, I would say one thing is that this is self-reported seeing of the messaging. And you can see that people in Utah and Washington also claimed that they saw the messaging, right? So what's up with that? Well, maybe in Washington, even though they weren't in that area, maybe they actually did see it, okay? But maybe they didn't if they were in Utah. I don't know. We don't understand that. Maybe it's just that they saw some messaging. And anyway, it's amazing that we got this result. We can talk more about it. I have to go on. Part 3, cancer and cost outcome measures. All right, the cancer registry data that we looked at was basically both from SEER and for Oscar, but we were able to get it. We thanks to Jake. I want a huge shout out to Jake Nelson, because Jake just, I mean, really amazing job at getting access to these data and then digging into them. And we also had help from Ruth Etzioni a lot in looking through that. So cancer registry data, subject level, which is pretty difficult. It's not difficult. You can get it, but it takes a while. SEER Medicare data, that's what Ruth really helped us to get with Kamal, Sonmez, and Gogobakan. And it combines the SEER registry with Medicare cost data, so you can see how that's working. And then you have an all payers, all claims database. And this one is almost impossible to get access to. And Jake did it. And it has basically all of the medical billing that goes on in Oregon. Basically, it collects all the ICD-9 and 10 codes, the CPT, the NDC drug codes, all of that. The only thing it doesn't have is it does not have Medicare, CMS, if there's no other private payer for the Medicare person. It doesn't include the VA, and it doesn't include Indian Health. But here's what we got. Remember, I'm going to tell you now about this cost data in this segment, right? We don't have things down here post yet. We've only got because part of the problem is that all of the SEER registry stuff, because of COVID, it's all messed up. And we got to return down to baseline a bit. And so we cannot make heads or tails really of what's going on with with the registries during COVID. But we can tell you for sure what's going on here with the that period of time from 2013 to 2019. So one of the things I think is amazing. So remember, we did a lot. We were doing a lot of awareness, but it wasn't that standardized messaging that we were doing. It was a lot of stuff we did though, right? We were making partnerships all over. We were doing skin screenings. We were doing, the educational curriculum was getting started out there and all that. So this is to show you what happened to our melanoma incidence and the percent change. And what you see here is this is the percent change in melanoma incidence. And these are all the states in the country here. And what you can see is this is where Oregon is. So we were the 5th best in the country in terms of movement between 12 and 19. This is where the United States is. And you can see that a huge percentage of the states are actually going up in incidence at the time when we actually managed to go down in incidence. So that's pretty cool. So in 2012, we had a rate of 27.3. In 2019, it had dropped to 25.1. We went from ranking 6th to 21st, the 5th best change. But we really care about mortality is what I really care most about. And between 2013 and 2019, what we saw is that Oregon is here, the 3rd best improvement. Oh, there's the United States. And you can see that we went from a rate of 3.4 to 2.0, ranking from 4th to 31st, being the 3rd best. And what I also like to point out here, which is really cool, is that nearly all of the states showed a decrease in mortality. And why is that? Because we've got great drugs that came on in 2012, 2013 that started to improve. And I'll show you some of that in a minute. So just to kind of show you, this is the melanoma incidence, mortality, and Breslow depth from 2013 to 2019. And the red is Oregon, the blue is Utah, the gray is United States, and the green is Washington. And so what you can see is that Oregon for incidence did decrease. You see that? That's what it did over that time period. Mortality rate decreased substantially. And substantially, that's really nice. But I don't know if the slope is any different than it is in Utah. The slope looks different than it is in Washington or in the United States, but maybe not that different in Utah. And that Breslow depth, if you look here, what's really interesting, it went up. Why did it go up? I don't know, but that may be able to give us some kind of clue if when the campaign comes back, when we look at this after that campaign, maybe they're going to start catching it earlier, but it doesn't look like it is now. So anyway, that's very interesting data. We don't know completely what to make of it yet. All right. This is the incidence of by melanoma stages, right? Because you might say, well, how did the incidence change? It went down a little bit, but how did it change relative to whether it was melanoma in situ or localized melanoma or regional metastasis or distant metastasis? And what's really interesting to me more than anything, I mean, you can look at these for hours, but what's really interesting is that it's pretty flat, if anything going up just a tad in melanoma in situ. That's okay. You're maybe biopsying more, maybe a little bit. The localized melanoma stayed flat. The regional stayed flat, but look at the distant metastases. It dropped the death. And so is this just telling us that the majority of the effect that we saw from 2013 to 2019 was due to the drugs that they were able to give for distant metastasis? Maybe so. But it's kind of interesting, especially given the fact that the Breslow depth went up. So we'll keep looking at that. So here's the cost. This is a wonderful paper, two papers that Kamal Gogabakan and Ruth and all of us put together. And it's just really interesting to look at the money that's associated. This is from the SEER Medicare cost analysis. What it shows is that you have the historical treatment period. What they did is they looked from 2004 to 2010, what it cost before you got all of the more advanced therapeutics. And then what it started to cost as you're starting to ramp up from 2011 to 2015 and the differences between those costs. And if you look at this, you can see that if you've got in situ, which is stage 0, the cost actually went down. Same for stage 1, went down. Stage 2 went down, but stage 3 went up. Well, you're starting to get some adjuvant care there for stage 3 with these therapeutics, and stage 4 shot up by $28,000 per person for the first year, right? So this is the average first year per patient cancer attributable costs after diagnosis by year of diagnosis and cancer stage. And again, you see the same thing, that these, when you take all stages, it flattens out, right? But that's just because the majority of cases are stage 0, 1, and 2. Stage 3 is up here in costs and stage 4 is up there. So we then went to the all payers, all claims database. And when we went to that, there's a problem because they don't have staging. So you have to figure out staging by what procedures and what results they got and what visits they had and things like that. So we developed a pseudo staging algorithm, right? Obtaining access to Oregon all payers, all claims database, identifying the codes that are specifically associated with melanoma, filtering the claims directly related to melanoma, identifying the codes associated with melanoma cases, and the drug codes for the pharmacy so you know if they were getting those good drugs. Developed an algorithm to categorize the patients into these pseudo-stage groups. And then we systematically categorized each case, because these are case level, remember. We're able to follow each case. We categorized each one into a pseudo-stage, an early pseudo-stage 1 and 2, which is probably not exactly 1 and 2, maybe 2B and 2C some of those may go into pseudo-stage 3, but it's pseudo-stage 1 and 2, 3, and pseudo-stage 4. And here's what we saw. So when you look at this, you can see definitely here, this is the early, this is the total amount of money paid, right? In 2022 US dollars, they're all adjusted for the US dollars. And this is how it's staying flat for the early stage. It's going up a bit for this, and it's going way up for the pseudo-stage 4. This is 3 and this is 4, or regional and distant, or whatever, however you want to think about it. It's a pseudo-stage. This is where we got ipilimumab, right? So that's what started to happen after ipilimumab. Then they got the targeted dabrafenib and trametinib. Then they got pembro. You're seeing these costs just go up. And these are all for stage 4 disease, though. Ipi-Nivo combo, BRAF-MEK combo. Then we start to get adjuvant. And there you see this cost going up in the stage 3, BRAF-MEK adjuvant. And then here, Pembro's approved for stage 2B and 2C, and we think that that's what's going on there. So it's nice because our pseudostages are sort of mapping really pretty well with what's happening in terms of cost of care. And you can see that if you look in 2011, for example, the total cost for all of these across the board, this is Oregon dollars that were spent on melanoma altogether in 2011 were $14 million. And in 2022, it was $46 million. So we're talking major increases, not such a huge increase in the lower stages and progressively going up. So what we did, which is really cool, and I have to shout out again to Jake, is he built a micro simulation model. And it was sort of inspired by the micro simulation that Kamal Gogabakan produced for that earlier SEER Medicare data. But it was, what we did is we looked at, is there a way that you could determine where, if you shifted the pseudo stage from the later stages over to the earlier stages, could you get a savings? And so you have to shift. If you're going to shift, for example, if you're going to change, if you're going to take people away from pseudo stage 4, they have to, a part of them have to go to 3, and a part of them have to go to 2 and 1, and a part of them have to go to benign, and same thing all the way up. So this is a model that's created to try to estimate what would happen. And what we saw was that if you over a 10-year period, this is over a 10-year period, but if you reduce pseudo stage 3 and 4 by 50% over 10 years, it's going to save us $37 million. This is Oregon, remember. And if you guys want to look at the micro simulation, just this is the little QR code. You can take a look at that. So here's my summary and conclusions. I went a little longer than I'd hoped because I want to have questions. I want questions. But the War on Melanoma is a unique statewide, prospective, controlled public health education experiment designed to determine whether a large-scale cancer early detection effort can improve literacy, reduce death, and decrease costs. The intervention running from 2019 to 2023 included 2 primary campaigns and a booster campaign, and it's garnered approximately 175 million impressions and exposed over 98 exposed an area that contains over 98% of the state population. Literacy was improved in the population that reported seeing the messaging, but was not observed across the entire population. Incidence of melanoma from 2012 to 2019 before the campaign dropped by 8%, and that changed it from 6th to 21st in the country. Mortality from 2012 to 2019 dropped by 41% in an era of improved therapeutics, got to note that, but taking Oregon from 4th to 31st, highest rate in the country. And additional analyses will still need to be performed after SEER APAC and possibly other literacy data is available, hopefully by 2027 is what we're hoping. So the whole point of what we do here is to eliminate melanoma as a cause of death. And I cannot thank all of the people. I saw some comments from Liz Berry, and I didn't applaud her enough. She should have been one of the ones that I was yelling out for. And there's so many people that have helped on this. And this is just an advertisement for a symposium that I think you all should go to. It's our Montana Symposium that Oregon runs, and it's going to be on mechanistic insights to emerging therapeutic platforms. So I thought in particular, this audience might be very interested in it. So that's it. Thank you. And I will stop sharing, and I would love to answer questions. No questions? Come on, somebody's got to have a question. Really?
I have a question. Can you hear me, Sancy?
Yes,
Pepper?
yes, Pepper.
So, you know, I've always been a huge fan of yours because I think you're a magician in terms of what you can accomplish. So you state that the war on melanoma is large in scale, and I would say it's humongous, and not something that many other people would be able to have accomplished in this period of time. So I don't know, when I see
Thank you.
$350,000 and I see just the campaigns, I don't understand, because I know what we spend in the lab and what impact we have, right? So I'm incredibly impressed, but I really want to know for the rest of us, if you were to knowing what you know now, what would you focus on for your campaign? Where do you think, if we wanted to do this for a subset of some other cancer, where are the most impactful?
Yeah. So I think you have to, the reason I'm kind of stammering is you have to break it down into what kind of category you want. I mean, one of the things that I think, in terms of the mass media that you're doing outreach, I think clearly the TV, radio, and social media are the biggest bangs for the buck. And so that's the combination I would use. And I would use one of the reasons we were able to get it for a less rate is because we're a nonprofit institution, right? And that makes us able to do, the Broadcasters Association has some special rates for groups. And so that's a big clue, a big hint for you there. I would definitely try to do that. And so that's that kind of media, but I don't think it's going to work. That's for the lay audience. I think that you really do need to promote with the PCPs. I think that the best is in person. I think you actually have to get an army of people going out and going to places. We have a lot in Oregon. We have a lot of nice satellite places that where we have medical centers that have grown, people together that you can advertise in that whole area, right? And you can bring people into those local areas and do it in person. And I think those partnerships are really, really valuable. For the skin service industry, I actually think that partnering with the OHA was the biggest, most important thing that we did. So actually partnering with them to help get to their license, the people that are relevant to them, and
So who's the OHA? I don't know
Oregon
the
Health
acronym.
Authority, the Oregon Health Authority. So I would definitely partner with them. I found, the Orprin and Ochin are incredibly powerful, but they're very, very expensive. They don't really partner with they can't afford. I don't want to make it sound like it's their fault. It's not their fault in any form or fashion. They have to sustain themselves, and so they have to charge for what they do. But that made it out of our reach to really do all the things. But those two groups are incredible and should be partnered with, especially if they've already got something going in the cancer area that you're interested in. So I think that's a big deal. So I know that's a lot of answers, but I think it depends, really it depends on what you want to do. Yeah. Yeah.
Hi, Sancy, it's Karen Eden. So good to see you. Amazing
Yeah.
presentation. So I just put in a grant and I managed to get Orprin to be the clinical face in the clinics and Ochin to do the data management, but it was brutal getting the budget to work. But we did. And I think there's going to have to be more partnerships because they're powerful partners. They
Oh,
really
yes,
are.
absolutely.
But my question is about Mole Mapper because, to me, it seems like, as I understood it when you showed it, there's some kind of image that is taken, and then the image must be uploaded to some kind of system that does some using AI or something to determine whether that mole is suspicious and needs to be evaluated. So then there's an ethical. So let's say
No,
it comes
it
back.
doesn't. It doesn't, Karen.
Okay, it doesn't.
We
Okay.
we never took this into clinical use. This is research. And
Okay.
so it doesn't, they get nothing back other than having the image stored on their phone and being able to compare
Okay.
it. But we do have an enhancement so that you can see the two images, the past and the present,
Yes.
side by side, so people can decide for themselves. But we never, because we're not FDA approved to do that. There's no FDA approved, to my knowledge. There is no FDA device approval for a handheld phone app to be able to actually do that. Now, there are a lot that are out there that are claiming they can do it, but I don't think that any of them are approved yet.
Yeah, I mean, I have to admit, so the app we use for our breast cancer risk tool, we do invite patients through MyChart. So there is a clinician that's available to take action as needed if somebody's at increased risk or has a new breast symptom. So that message goes to the triage nurse. But there's been pressure on us to make it publicly available, but we are hesitant to make it publicly available because what happens if somebody needs care?
Yeah.
Who's responsible if they need care? So I totally understand.
Well, yeah, and see, it
piece
was
of
one,
this.
yeah, so that was kind of why we did the e-visits, because in Oregon, we
Yes.
knew we weren't going to be advertising across the country, but when you're talking about an app, it gets out everywhere. And so
Yep.
then are you responsible for, you can't do
Yep.
e-visits for everywhere. You might be able to handle e-visits from one state, but you're not going to be able to do them. I mean, you know, it's a mess. That's a tricky, sticky wicket or something. What do they call it? I don't know. That's a
Yeah.
tough one. Yeah.
Amazing presentation. Thank you so much. And so good to see you.
Oh, thank you. Same here. Same right back at you.
Hey, Sancy, it's Missy Wong.
Oh,
Really
Missy,
good to
hi.
see you and miss you terribly, but you look really good.
Well,
And your
I miss you
presentation,
guys too.
amazing.
I do.
I guess my question is, you know, you have done just a tremendous amount of public service, but then at the same time, you have to make sure that patients who feel like they have suspicious spots have clinicians to see. And so how do you, in parallel, you know, make this huge public awareness, but then grow the clinical capacity to really be able to treat the patients that now have educated
Yeah.
awareness of screening?
Yeah, yeah. You know, I think that's exactly what I was afraid of, right? I mean, that's what you just described was I was terrified that we were going to launch this campaign and then everybody that had a seborrheic keratosis, a benign seb on their skin, was going to run to their PCP and ask them, you know, what was going on. And if that happened, then we were going to make enemies of all of the PCPs because they have real disease to take care of. They don't need to take care of a benign seb, you know, and we're going to make enemies of them. And what if they didn't have a dermatologist? What if there was nobody there, you know? And so we were terrified. That's why one of the very first things I did was start that e-visit program. And I think it absolutely is critical, and it has to be done inside of OHSU, right? But OHSU wants to support e-visits and e-consults and all of that, you know, and the e-visits help the people who want to come directly that don't have a dermatologist. The e-consults are the people that go to their PCP. We can be consulted by the PCPs to, you know, help them if they find a lesion that they don't know what is. And that's why our numbers went up. I mean, I think you saw in the e-visits and the e-consults, they really, really jumped. And I think we have more e-visits and e-consults than any other service in the institution at OHSU. And I think the reason for that is because we actually are using it to do it's a safety net. It is our safety net for being able to, and the store and forward that, you know, the other problem with it is for other cancers, you know, and I don't mean to, you know, say you couldn't do it. I think you'd have to really think hard about it though, because what's really nice about the e-vis is that you can do a store and forward. They can be responsible for taking the picture and they get it to you. And if it's not a good enough picture, you send them a clip. And if then that's a good picture. And then they send it back and you can do this and you can look at a picture and know within seconds whether it's something that you really think is worrisome or not and it needs to come in. And then you have to have enough spaces where in your panel of providers, you have to have enough spaces for that 50% that still have to come in or whatever it is that still have to come in. Yeah. It looks closer to be 30%, by the way, now. It looks like only about 30% of the people that are sending in e-visits. I think that's the latest data. Melissa Schwartz is on. Melissa, is that right? 30%? Are you still on? I don't know. She may have had to go.
I don't know if you saw, Sancy, I sent you email, but Amanda Zucker got her Melanoma Research Foundation grant. So thank you so much
Oh,
for supporting
that's
her in
great.
that.
Yes, that's great. Tell her congratulations from me.
I will.
Okay. Well, I think we're past time. So I am always happy to answer any questions. I saw that there was a bunch of things coming at some point in the chat, but if you wrote something for me in the chat that you wanted to have answered, then please send it to me by email because I didn't really see it very well. And my email is sancy.leachman at HSC for Health Science Center .utah.edu. And one last thing is, you guys know I'm still officially affiliated with Knight Cancer Institute. I still have an affiliation. So I'm very proud and very happy about that. So thanks for having me talk.
Thank you, Sancy. Wonderful seeing you.
Yeah, same here. Same here. Bye-bye.
Thank you, Sancy.